So we are the experts in the United Nations for anything related to health. When people think of the WHO, they often think of people like Dr. Dwangvadi and and myself. They think of the people who work for WHO, the organization, the WHO. That part of the WHO that we call the Secretariat. In reality, WHO is made up of two very important organs. The Secretariat, myself, is one of them. The second is called the World Health Assembly. For those and I'll talk a little bit about that in just a second, but for those who've never seen the WHO, who've never been there, you should go sometime because it's very beautiful. This is our headquarters building located in Geneva, in Switzerland. So the first organ of the WHO is called the World Health Assembly. The WHA, it's called the World Health Assembly, abbreviated to WHA. It is the supreme governing body of the World Health Organization. It meets once a year in Geneva, Switzerland, and it is attended by delegates from all of the 194 member states of the World Health Organizations. The delegations are usually represented at the ministerial level. So basically, once every year in May, all the ministers of the world come to Geneva and they meet to discuss issues about health. The World Health Assembly is like the board of directors of the WHO, okay? This is a photo, I think, of the WHO in 2015 when the president of Germany, Angela Merkel, addressed the World Health Assembly. So this is a very august and important body that really directs the work of the WHO. And I'll be talking a little bit about some of the things that they've resolved. So the main function of the WHO, the WHA rather, the World Health Assembly, is to adopt international conventions, and really importantly, it's to make recommendations to all the countries on specific issues related to health. And this is why I'm talking about the WHA, because in specific issues related to patient safety, accreditation, it is the World Health Assembly that proposes and ratifies recommendations for use across the world. So if a resolution is made by the World Health Assembly, it means that all of the ministers, health ministers of the world, have decided that this is an important issue and that this issue should move forward, okay? Among other things, the World Health Assembly elects our Director General, okay? So our Director General is elected by all of the ministers of health of the world. And of course, they review and approve our budget. So if they want to direct resources of the Secretariat of my office to patient safety, they will tell us that that is exactly what they want to do. So the second organ, so I've talked about the World Health Assembly. The second important organ is the Secretariat. That's me. That's Dr. Dwangvadi in her former life, okay? It's all of the staff of the organization who help the member states, the countries, to implement the resolutions of the World Health Organization. So if there is a resolution about patient safety, it's the Secretariat, myself, my staff, that help the countries to implement those resolutions. We have about 8,000 staff around the world. And as I said, the Secretariat is led by our Director General. She's from China. Her name is Dr. Margaret Chan. The DG is elected every 5 years, okay, and he or she is allowed to serve up to 2 terms. And it's quite significant that in May of this year, we will be electing a new Director General. So the member states will be electing a new Director General. We have 6 regional offices, and this is important because Thailand belongs to one of our regional offices. We belong to the Southeast Asia Regional Office. There are 11 countries, and we are led by our regional director, Dr. Poonam Ketrapal Singh. Okay? And finally, the WHO has over 140 country offices, mine included. Okay? So the WHO country office in Thailand is located in Nonthaburi. Okay? We have about 29 staff there, national staff and international staff. You are all welcome to come anytime to visit us. We're based in the Ministry of Public Health in the Department of Disease Control building. So the World Health Organization has a constitution. Since April 7th, 1948, or 69 years, ago our Constitution was made. These are the key principles of the Constitution, and they really sum up the mission of the WHO. This is what we do. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Okay, that's really critical. The enjoyment of the highest attainable standard of health is one of the is the fundamental right of every human being. And I think from this you can see why the WHO is very interested in the concept of patient safety. The whole concept of patient safety fits into our Constitution very, very well. Now I'd like to take some time to discuss some concepts around patient safety and what we mean by the term. Is everybody in the room an expert in patient safety? Yes? A little bit? No. Okay, I'm going to talk then a little bit about patient safety. I'm going to present a little primer on patient safety just so that we're all oriented. This, of course, is an excerpt from the famous Hippocratic Oath. If there are doctors in the audience, you will have recited this oath when you graduated, when you matriculated. I did. The oath says that I will prescribe regimens for the good of my patients according to my ability and judgment and do no harm to anyone. Okay? I will preserve the purity of my life and my art is healthcare. So the Hippocratic Oath is really about protecting people. Okay? It's about protecting patients. I talked previously about our Director General. There she is, Dr. Margaret Chan. And she has said, and I think Dr. Duangvadi actually quoted her previously, but I think it's worth repeating, that our knowledge of diseases and technological innovations have all contributed to increasing life expectancy in the 20th century. That's clear. But one of the greatest challenges is not keeping up with the latest clinical procedures or the latest high-tech equipment. It is really about delivering safer care in complex, high-pressure, and fast-moving environments. In such environments, things can go often wrong. And that's really what she is alluding to here, is how we protect patients. It's the whole concept of patient safety and how we do it in a very complex and very high-pressure clinical environment. So what are really the main messages in relation to patient safety? There is now overwhelming evidence that significant numbers of patients are harmed from healthcare. Okay, we know that. Patient safety is an issue in all countries that deliver health services, whether these services are privately commissioned or funded by government. So a lot of patients harmed, and this is a problem all over the world. Studies have shown that many adverse events in the clinical care context are preventable. One study found that more than 2/3 of the adverse events in a sample were preventable. 28% were due to the negligence of a health professional, and 42% were caused by factors other than negligence. So a lot of preventable adverse events occurring in the clinical care context. Over the last decade, we've learned a lot about why this happens. And we've learned that adverse events don't occur intentionally, okay? They rather occur due to the complexity of healthcare systems. And I'm going to talk a little bit about that and why that is, and present some interesting models that show why that might occur. And when so many different types of healthcare providers are involved, it can be very, very difficult to ensure safe care. The situation in developing countries merits particular attention. Now, Thailand is not a developing country. It is a upper middle income country. But where I worked all of my life in Africa, the issues around patient safety were front and center. Hospitals were simply unsafe places to go. And many of the features of patient safety programs do not involve financial resources, but rather commitment of individuals to practice safely. So this is not something like the eradication of polio, which requires millions of dollars. This is something that can be done relatively low cost, relatively locally. So I just want to talk a little bit about the burden of unsafe care. How big a problem is it? In developed countries, and again, I think this statistic was already quoted, about 1 in 10 patients suffers an adverse event in hospital, okay? That means that for every 10 people that goes into a hospital, 1 in 10 will suffer an adverse event. This rate is higher in transition countries, like Thailand, and it's extremely critical in developing countries. Again, like I say, countries, for instance, in Africa. There are really 6 main types of adverse events, and I just want to go over them very quickly because WHO has some very specific initiatives that address these events. The first are nosocomial infections. We're all familiar with healthcare-acquired infections. 1 to 2 out of 10 patients acquire these, mostly in the intensive care setting. $5 million in Europe, 5 million occur every year alone in Europe. 5 million nosocomial infections every year in Europe. And you can imagine what a problem this is. Most of these infections are related to complex microorganisms that live in hospitals, and you can imagine what a problem that is for another global health priority, which is antimicrobial resistance, okay? So decreasing nosocomial infections, improving patient safety by decreasing nosocomial infections is a critical intervention for antimicrobial resistance. The second adverse event is medication errors. We know that these compromise a significant burden with up to 1.5 million persons harmed every year in the United States from medication errors. Unsafe surgery, wrong patient, wrong site, wrong organ, etc. These are 1 million deaths each year from complications of surgery, which are listed here. The fourth is compromise to patient safety that occurs during clinical handovers. Okay, the handing over patients from one shift of doctors to another, from one shift of nurses to another. The miscommunication of information is a critical problem that can lead to some patient adverse events. The fifth is related to injection safety. 70%, as you probably know, many of you are involved in primary care, 70% of injections in the primary care setting are not needed, okay? And they account for many cases of hepatitis B and hepatitis C globally now. And finally, there are a large number of other risks. I've talked about 5 of the most important ones, and these are, I think, the 5 that we really need to keep in mind as we think about how we can address this problem. So not only the burden of compromised patient safety is most tragic when we think about human beings, okay? But it's really important in the era of escalating costs and the need for more efficient health systems to think about the economic burden of unsafe care, okay? In the United States, the annual impact of medical errors and adverse events has been estimated at $60 billion. Can you imagine what the world could do with $60 billion? The budget of the WHO is, I think, $4 billion. I mean, $60 billion is a massive amount of money lost to compromised patient safety. The impact of, for instance, of nosocomial infections alone that I talked about before accounts for about 25 million extra hospital days, or about $6.5 billion in the United States alone. So the economics, not just the human burden, but there is a huge economic burden in relationship to patient safety. One of the major messages of my presentation is that patient safety issues are systems issues. And I think this is really a major message coming out of certain global initiatives and regional initiatives. Dr. Lucien Lippe, who's a Harvard professor and has been very active in trying to improve the medical system to reduce medical errors, has said, humans fail because the systems, tasks, and processes in which they work are wrongly designed, okay? This is, of course, applies to patient care settings. So it's not necessarily the people, it's the systems. Another person who's made a significant contribution to this field is James Reason. He's a professor of psychology at the University of Manchester in England. Some of you may have heard of him. He created what is called the Swiss cheese model of accident causation, okay? I'm going to talk a little bit about it because I think it's very, very interesting. And it's used in risk analysis and risk management. And the model applies to health, but it also applies to aviation. It applies to anything, any complex system where something can go wrong. He stated that only a systems approach okay, as opposed to the more common approach of blaming individuals or based on individuals. Only a systems approach will create a safer healthcare culture. And why is that? Because it is easier to change the conditions under which people work than it is to actually change human behavior. Okay, it's easier to change the system, the hospital system, the healthcare center system, than it is to change the behavior of the people. And he used examples from industry to demonstrate this, and he used what is called the Swiss cheese model. And I like this because I like cheese, but also I like to show this because it's kind of interesting. Have any of you heard of this model before? Okay, I'll just go over it very quickly. He basically, many of you may know Swiss cheese. When you slice Swiss cheese, each of the slices has sort of holes in it. And Professor Reason argued that the occurrence of adverse events can be likened to Swiss cheese, okay? Every step in any process has the potential for failure, okay, to varying degrees. So consider each hole in the slice of Swiss cheese as an opportunity for a process to fail, and each slice of cheese as a potential defense mechanism against failure. An error may pass through one layer, but in the next layer, the holes are in different places, and the problem is caught and deflected. It does not pass through. Each layer is a defense against potential error occurring, and I think that you can see that here in this diagram. In the patient care context, the defenses which prevent minor mishaps turning into major failures include standardized procedures, such as guidelines and protocols, physical barriers, such as the separation of different types of high-risk drugs, information such as on patients, such as patient allergies, and decisions that clinical staff take based on their training and their experience. For a catastrophic error to occur, and I think many of you may have had experience with very serious errors, the holes need to align for each step in the process, allowing all defenses to be defeated. So the holes have to line up so that the problem passes through each layer of defense and you end up with the serious problem. If the layers are set up with the holes lined up, it means the system is flawed. Okay? It's flawed because it allows a process that starts at the beginning to progress all the way through to the outcome. So you can look at each slice of cheese as an opportunity to stop an error. So in the systems that you have, in the context where you work, you can think of the various systems that you have as slices of cheese. And the idea is to make sure that if an error passes through one slice of cheese, that you have a second defense to catch the error, and then a third defense and a fourth defense. This is a really critical concept, a really critical basic concept in patient safety. How can we reduce adverse events in patient care settings? And it's not by punishing individual practitioners. The key is to, as I said, is to fixing dysfunctional systems. Healthcare providers should look beyond healthcare mistakes or failures in care and understand that there are many factors associated with an adverse event. This is really about about asking questions about the underlying factors and encouraging others to think about errors from a systems perspective. This means asking questions about possible causes by using the phrase, "what happened," rather than "who was involved." One method that we used in the Ebola outbreak when I was in Sierra Leone, when healthcare workers were infected, is we kept asking the question, why? Why did this happen? Okay, why did that happen? Okay, why did that happen? Why did that happen? This is critical. Rather than saying who, it's really asking why. Why, until you get to the bottom of the problem. And as you ask why, you'll see that you'll see the flaws inherent in each slice of cheese, in each system of defense as you move along through your system. So many factors and structures and processes contribute to unsafe care, complex and high-pressure healthcare environments. I think we've talked about communication failures and ineffective healthcare teams, poor reporting and learning from errors, poor quality clinical care, lack of involvement of patients themselves in the care, unsafe clinical practices resulting, again, in nosocomial infections, surgical anesthesia errors, unsafe use of medications, unsafe blood practices, and of course, human factors. The relationships that members of a healthcare team have with each other. And I think that you, as healthcare leaders and providers, should, when you think about improving your own systems, follow these basic precepts. Really avoid blaming when an error occurs, okay? There are more opportunities, look at opportunities that you have for reviewing the systems that lead to errors in your healthcare contexts. Practice evidence-based care, and this is coming from WHO. WHO is all about evidence-based guidelines, using evidence to create guidelines and resolutions. So healthcare providers should learn how to apply evidence-based guidelines, and they should be aware of the role of evidence-based guidelines and how to improve them and apply them. It's really critical to maintain continuity of care for patients. The health system is a continuum of care for patients and their families. Understanding the journey that patients make through the health system is necessary to understand how the system can fail, okay? Important information can be missed, outdated, or incorrect. This can lead to errors. It's important to be aware of the importance of self-care. Healthcare workers should be responsible for their own well-being and that of their colleagues. Healthcare providers in difficulty, who are exhausted, fatigued, who have problems related to mental illness, should be encouraged to seek the appropriate professional help. And of course, this goes without saying. It's part of the Hippocratic Oath. It's part of why we're in healthcare, to act ethically every single day. So just to summarize up to now, unsafe care and harm to patients is everywhere. It's a global concern. Patient safety is still not a priority in all countries. I can see, even just after a year of being here, in Thailand, patient safety is a priority. But in many, many countries, this is not a priority. Adverse events can happen because of errors in human behavior, structural factors, or poor processes in healthcare. Learning and lessons and learning about errors and system failures in industry can be used to develop frameworks for improving patient safety in the healthcare context. And that, I was just talking about the Swiss cheese model. That comes from industry, and it can be used to think about how we improve patient safety in healthcare model.